Great. I'm Darshak Sanghavi. I'm the Chief Medical Officer of Optum Labs. Optum is part of the United Health Group. And what I'm going to talk about is essentially how does a massive payer make the decision to scale something? So I think for some time, we've been talking about what can we do to enhance weight management broadly. There's plenty of pilot programs like meta-analyses and data, but the question is, how do you do this at scale? So what I'm going to talk about is sort of loop you all into a series of areas of murky uncertainty where you need to make decisions based on limited data, and how that decision at least was made last year when I was a Director of Prevention and Population Health at CMMI and CMS. I think these same lessons can apply at United Health Group. We're a Fortune 6 company. We're the largest commercial insurer in the country. Similar types of conversations happen there. But for obvious reasons, I will talk more about how CMS thinks rather than how United thinks, although the concepts are similar. So here's a problem we're trying to solve. Everybody knows that the diabetes prevention program works. Everybody thinks, I'm just going to stipulate here, that healthy weight is a good thing. We all think that this is probably good for many, many reasons, least of which is that it seems to improve the outcomes of people who are suffering from cancer or who are long-term survivors. And yet, nobody pays for it. Nobody puts their money where their mouth is, so why does that happen? And the answer is pretty simple, which is that the benefits, first of all, really getting weight loss is expensive. It's extremely time-consuming. It's not reimbursed well. And the reason it's not reimbursed well is because the benefits are not seen for many, many years. And so the people who pay for the care are not the people that are benefiting from the care. So the problem we are trying to solve is how do you create a business case for investments in weight management so that it is compelling enough to get people to actually invest in it? So let me start. I'll put that out there. So everybody's familiar with the data here. We don't need to talk about the data. This is really largely, I'm just going to put it this way, this is a business and political problem. It is not a medical problem. So how do you solve it? Well, I'm going to give a little bit of background, and I have about 7 slides here. But for those of you who are not familiar with how CMS and CMMI are structured, the federal government invests in large pilot programs through Affordable Care Act authority to do tests. That's where Pioneer Accountable Care Organizations, Comprehensive Primary Care, which is a medical home model, the Oncology Care model, Million Hearts model, all those are being run. One of those programs was an investment in the diabetes prevention program is delivered in community-based settings by the YMCA. I know Matt Longjohn was here. Some of you probably talked about that earlier today. The way this works is if those programs either save money or improve the cost of care, ideally do both, and are actuarially certified to do those things, then those programs will be expanded across the country as a Medicare benefit. And the reason that's important is because although we in the private sector like to think that we are the major innovators in coverage, many times we follow what the feds do first. So this is why this is so high, this is of such great importance. So I'm going to do I'll try to be honest with you about people rarely talk about the real numbers and the ways these decisions are made. You're going to hear how that was done now. These slides are projecting a little small, but let me just sort of summarize what this shows. What this shows is clinical outcomes for the diabetes prevention program in a variety of different areas. For those of you that can see the orange line there, we knew that for about a year or 2 of data, that's all we had for the YUSA DPP, for several hundred participants, we were able to see weight loss, which was commensurate with what the CDC DPP trial did. Only a year or 2 of data. We did not have glucoses, lab values, or anything like that. All we had was that weight was reduced at approximately the same amount as it was in the DPP. So from the clinical standpoint, the question is that good enough? I'll leave that as an open question. We'll come back to it. This now is the impact on total cost of care. So let me lay out a couple of additional challenges for any of you who are health services researchers. The diabetes prevention program, as delivered by the YUSA, was non-randomized. It took place in 17 markets across the country in a Medicare population. So as with any sort of big intervention, we knew who they were, and we were able to track their expenses over time. How do we tell if we save money? Well, it was non-randomized. So a propensity match control group was created by our contractor, which at the time was RTI. This right here demonstrates the difference in cost of care depending on the exposure to the program. And you can see that over the first 5 quarters of the intervention, the total cost of care of the Medicare beneficiaries in the DPP appeared to be less than those that were in the propensity match controls. I would just raise this as an issue. Do you find this data credible? The approximate immediate benefit was about $500 per quarter. So we estimated, I forget the exact amount, so don't quote me, but roughly within the first 5 intervention quarters, the savings estimate was about $1,500 per patient. For those of you who are in this was very complicated and highly controversial. Many people said, you can't get those kinds of savings benefits immediately. You have some foul up in your propensity matching. But we said, well, you know, our RTI, these are the rules of the game that were set up, so to speak. This is sort of the predetermined endpoint. So the first question I'd ask is, this is all the data you have. This was done on several hundred people. Are you convinced that this demonstrates cost reduction in a way that could be actuarially certified as cost saving? And would you create a national benefit? So this is one of the reasons I asked a question earlier this morning about, like, okay, that's all fine, well and good. We have all these academicians up here. Are you willing to say we should do this? And the answer was very telling. The answer was, we need more studies. We do not have that luxury. So I would really ask all of you, like, do you want to wait 5, 10, 15 years for those studies, or do you feel comfortable putting your money where your mouth is, so to speak? That's what I would say. Do we feel that way? And this is the decision that we had to make at CMS. There are also political realities. At the time, we didn't know, you know, the Affordable Care Act, is it going to be around? Do we have this authority? I mean, we had no idea what was going to happen, but all those sort of realities, we really try to insulate those quite a bit when at CMS, and I know some people here know how this works. You really try to be as faithful to the data as possible, but all those realities do exist. So I'll just put out there, would you have certified this program for expansion? You know, just say to yourself, is this good enough for you, your academicians? This is the same, by the way, all this is public knowledge. These are all data that's clipped from publicly available reports that were posted after all these discussions were had. So you could go online and find them all, play with the data yourselves. But this points out that savings estimate over that period of time. So we concluded that we, meaning a small group of us, that we put together a little Delta force at CMMI. We had colleagues at CDC and others, with the blessing of the actuaries, put together a work group that was fairly small, about a dozen people. We looked at this data and we said, this looks very, very promising. We are public health advocates. We look at the data, but we're going to push to see if we can get this actuarially certified. Getting something certified by the actuary is very, very challenging. I just want to put out there, for those of you who follow CMS, do any of you know how many models, of the $10 billion in models that were put out there, how many have been certified for expansion? At the time we started this. Anybody know the answer to that? 0. Okay. The bar is very, very high, is the point I'm making. Actually, Pioneer ACO was certified as showing being cost saving, but the expansion for that was not the creation of a new benefit. So that's fair to say that. But the bar is very, very high for what gets certified for expansion. So we started to go down this path. And so a group of us also then put together this particular way the benefit was designed. If we were going to expand it, we wanted to make it value-based. This was what was created really through a process that I would refer to as expert consensus of the dozen people. You can sort of look at this, but the bottom line is heavily weighted towards achieving goals. Attendance and actual weight loss in the first year, followed by maintenance of the weight loss for indefinitely over years and years afterwards. So we designed this as a benefit that would continue over time to ensure that people got that follow-up care that they needed. And we were struck by the fact that one of the disparities we see is that the FDA approves drugs that cost $1 zillion based on studies looking at many, many fewer people. But for years, a provision of face-to-face care is subject to much higher standards of evidence. So that was also in the back of our minds. Why are we making it so hard for face-to-face and behavioral interventions when we are willing to have very different standards? And that's just the way it is. But this is on the back of our minds, like, what can we sort of blaze the trail in this way? So what happened then? Our Office of the Actuary is very interesting. In December 2015, we had an incredibly thoughtful and very productive relationship. But they actually said, this is great, it's all going to work, but unfortunately, we're going to, if we expand the DPP, things are going to cost more. Does anybody here know why that would be? You got it. You live longer. So for those of you who sort of went through this with tobacco years ago, maybe Anand, you're a veteran of the tobacco wars for a long time. You know, one of the big problems is if you live longer, you cost more. If you cost more, then... So in other words, what this was saying is that one could not certify a preventive benefit if you were going to live longer because you would always cost more. So this is a very, I mean, it sounds sort of funny, but it's actually a little, you could see where the actuaries are coming from, right? Like the budgets are the budgets. How would you solve this problem? Anybody have an, I mean, just say, maybe I'll, rather than sort of making this too interactive, just say in your heads, if you were at CMMI or CMS, many of you are highly familiar with how these questions are worked out, what would be the solution you would propose to this problem? And this is a problem that, remember, this will reverberate through all of the entire payer community as well. Is CMS going to sort of say, we can't certify because you live longer? But that's sort of what it said. Sorry? Look at the future value of money. What does that mean? Yeah. Yeah. That could have been one way to go. Our actuaries actually did discount for time, and they said you'd still lose money over time. But that's certainly one way to go. I'll just tell you. Well, I don't want to take away from more time here. So this is sort of where I think this is where advocacy comes together as well. So what we concluded was we talked again, and this is, I think that a lot of this work, while the fact is a lot of it depends on data, and a lot of it depends on academic work and randomized trials, a lot of health policy, if there's one thing I can leave you with, is about personal relationships, advocacy, and also fighting for what you believe in and being creative. And so what happened was we sat down at CMMI with Patrick Conway, who is really, the thing about Patrick is he always says, tell me more. He doesn't say no. I love that about Patrick. And then we worked with people at the actuaries, and this is what we concluded. We said, this is contrary to the integrity and values of who we are at CMS. Future life should not be counted as a cost, period. We just, I'm putting it sort of in other terms, we just changed the rules of the game. So this was not really well publicized, but this was posted the same day the DPP certification was publicized just about a year ago. It is, as opposed to a 1,000-page memo, it is a 2-paragraph memo that we pushed, and our general counsel must have been in a very good mood that day. They let this go through, and this was posted. And it's a little bit challenging to read, but the last sentence, I'll just read it to you. The Center for Medicare and Medicaid Services has made a determination that costs associated with expected improvements in longevity are not appropriate for consideration in the evaluation of net program spending. In those words is sort of the critical piece that we need to sort of think about how we should consider investments in long-term prevention and in population health. I think this sort of started to go down that path, and something we were very proud of, although it was done really sort of under the radar to some extent. But this is now, at least for the time being, the policy of how CMS will think about these types of expenses. And we hope that this also in some ways affects how we think about investments in prevention as they go through the larger payer community. So I'll stop there.